Now I request Dr. Leila Mohan to present her talk on strabismic amblyopia. All of you know that Dr. Leila is a well-versed strabismic person. She is the head of the department in Comtrust Eye Hospital. Over to you, Dr. Leila.
Thank you, Dr. Elizabeth. So, coming to evaluation and management of strabismic amblyopia. Strabismic amblyopia is the commonest form of amblyopia, as already pointed out, constituting about 40% of amblyopes. And any constant misalignment of eyes during the development of binocular vision, leading to inhibitory neuronal interaction of the non-fusible visual inputs, leads to active inhibition of the cortical neurons to prevent diplopia and leads to dominance of cortical areas of the fixing eye. And so structural and functional damage occurs in the lateral geniculate body and visual cortex, and early alignment can prevent this structural and functional damage. And strabismic and anisometropic amblyopia can also coexist, as already mentioned. That is, a combined form can exist. And often defective vision is detected in school screening, and strabismus may have been noticed by the parents earlier, but they may have overlooked this and they come late. Coming to the pathophysiology, in strabismus, both retina receive stimulus of the non-corresponding areas, hindering fusion of images from both eyes. So, the layers observing amblyopic eye atrophy. You can see in this right and left lateral geniculate body, right lateral geniculate, there is obvious atrophy in the amblyopic, the stimulus coming from the amblyopic right eye in the laminae 2, 3 and 5 supplied by the amblyopic right eye atrophy, and left lateral geniculate body there is atrophy of layers 4 and 6 supplied by the from the stimulus coming from the right eye. So, some clinical features are very specific to strabismic amblyopia. In strabismic amblyopia, there is a stimulation of non-corresponding retinal areas and a very strong suppression component is there. Contrast for higher spatial frequency is affected more, whereas in anisometropic amblyopia, contrast sensitivity of all frequencies are affected. Abnormal accommodation response is also more in strabismic amblyopia, and crowding phenomena are seen more pronounced. Crowding or difficulty in reading a letter when it is surrounded by other letters or contours. They read the first and last letters in, when you check vision by Slendil, and the middle ones are often omitted. Critical distance for crowding increases with the retinal eccentricity in strabismus. That is, the more the angle of deviation, more is the crowding phenomenon. So, the readiness in reading is also reduced due to this same phenomenon, crowding. ETDR chart gives an idea of crowding. Temporal crowding effect, that is a deficit in motion perception, also is affected, and increase in latency of response to stimuli is also seen in strabismic amblyopia. So, temporal crowding can be measured by rapid serial presentations of optotypes. So, some predisposing factors in strabismic amblyopia. Strabismus may occur due to high uncorrected refractive errors. Hypermetropia has a higher risk of developing esotropia and amblyopia. Binocular fusion anomalies can produce strabismic amblyopia. Neuromuscular or orbital anomalies or pulley dysfunction can predispose to strabismus and amblyopia, those who are predisposed. And esotropes are more prone to develop constant strabismus and therefore amblyopia. Essential esotropes should have early alignment for fusion, otherwise they will go for amblyopia. So, the fixation behaviors can be looked at in a child. You can see this child has a freely alternating esotropia, and this essential esotropia, which shows that he has more or less equal vision, and this central steady maintained fixation shows that he has equal and better than 618 vision. In this second child, you can see he is trying to avoid closure of the right eye, which means he is avoiding the vision with the worse eye. If there is no central steady and the fixation is not maintained, that means his vision is worse than 636, and if it is unsteady, that means his vision is worse than 660. And in the older child, you can take vision with age appropriate measures. This is HOTV or picture charts can be given to see whether amblyopia is there or not. So in essential esotropia, infants easily switch fixation from one eye to alternate fixation after occlusion. Up to 18 months is the period of maximum sensitivity. So after a proper evaluation to rule out refractive error and fundus examination, if there is a preference of fixation, as we have already seen, patch the eye for 2 to 4 hours a day, depending on the age of the child. If it is very young, about 6 to 8 months, then 2-hour patching is more than enough, and bring the child back after 1 month, they start alternating. Then you can go for the surgical correction. Bilateral medial rectus recession can be done, and follow up for binocular vision, which is very important. During follow up, this is the technique using a 10% base down test to see whether both eyes are being used equally. So when the eyes are straight, you don't know whether he is fixing with both eyes, his vision is equal in both eyes or not. So that gives you an idea of whether he is using both eyes equally. So in an older child, of course, we can check vision with picture chart or Snell lens, and patching should be continued if he is fixing with one eye or his vision is worse in one eye, and 2 hours in mild to moderate amblyopia, as already shown by Dr. Andrews, 6 hours in severe amblyopes, that is if the vision is worse than 636, and they should be followed up. 40% of essential esotropes can go for hypermetropia and residual esotropia, or recurrence of esotropia also. You have an orthotropic child, but if you don't follow up, they will go for essentially recurrence of esotropia. So they have to be followed up for refractive errors in future also. So factors which increase, because you have operated the child at 1 year and you don't know the actual vision. So visual acuity should be followed up, refractive status should be followed up at least for up to 4 to 5 years. Factors which increase demands on fusion can also disrupt fusion, produce strabismic amblyopia. Hypermetropia of more than 20, in children with hypermetropia, more than 20% will go for esotropia. Hypermetropia of more than 3.5 diopters in one meridian at 1 year has 50% chance of esotropia. So they have to be followed up. So this child at 4 years had a atropine refraction which showed +4 diopters of hypermetropia, which was fully corrected. Hypermetropia, when you give full correction, it is better to give as and when the child is atropinized, because the child will tolerate the full correction then. If you give after 1 month, they may not accept the full correction. So if vision is not equal after 3 months, patching should be started, and repeat cycloplegic refraction after 6 months to see whether there is a residual hypermetropia, and look for binocularity. This child, she was fully corrected with +3 diopters and lost for follow-up, and she came back after 3 years decompensated, and she was not fully corrected with full correction, which was given later. So it is very important that you follow up these children. They may become partially accommodative. This child, he has an isohypermetropia, which is a very important stimulus for strabismic amblyopia, and this is a combined form of refractive and strabismic amblyopia, where he had 3.5 in one eye, 6 in left eye, and patching improved his vision from 6:18 to 6:9 after correction of the partially residual esotropia by surgery, and then followed up with patching, and his stereopsis also improved to 120 seconds. So you have to correct surgically also. So they may go for microtropia also. All these strabismus after surgery, they can go for a foveal suppression scotoma with ARC. A prism base out test will tell you whether he has a microtropia. So when there is a near distance disparity, you may have to give a bifocal correction. Sometimes they may have a distance and near deviation with near more than distance. You may have to go for correction with surgical correction along with pulley fixation or fadernization. So combined strabismic and anisometropic amblyopia, combined mechanism is defined as any strabismus by PBCT and more than 1 diopter difference between both eyes. So even if strabismus is not fully corrected, if you give correction of refractive correction, they may improve vision and get corrected. So patching will have to be instituted in the rest of the children after 12 to 16 weeks. That is, if they are not corrected by refractive correction. And some small angle tropia may convert to microtropia in these cases. Some other strabismus, like congenital superior oblique palsy, for example, they are compensated well by an abnormal head posture. As you see in this child, there is no hypertropia. But if there is an anisometropia, they or anisomeridional astigmatism, they may decompensate. So if you correct them early surgically, they will for this child, he has no head posture later, so they have to be taken up for surgery. Otherwise, they will go for amblyopia. So in small angle residual esotropia, a Botox may encourage fusion, but amblyopia has to be corrected and continued. Continued stimulation should be there. So whether strabismus surgery can be done before complete treatment of amblyopia. So practice patterns say that you have to treat amblyopia, but you cannot wait for long, because the sensitive period is the time when you need to align the eyes. So BSV and stereopsis depend on motor alignment and equal vision within 24 months, especially in congenital esotropia, congenital exotropia as well. So often complete treatment is not possible for amblyopia then. So alignment should be done and surgery can be done, and then continue patching and strabismus treatment. Binocular stimulation, for binocular stimulation with dichoptic treatment, it is important that you correct the strabismus first, or if it is not fully corrected, small strabismus can be corrected with prism and then continue with the dichoptic treatment. And perceptual learning, as already pointed out, can be continued in adults also after surgical correction. They may improve. So some newer insights: foveolar thickness in eyes have been seen to be more in amblyopic eyes, and OCT fixation shift can be used in detection and quantification of eccentric fixation in children with residual strabismic amblyopia. You can see this is the foveal fixation. Here it is a little shifted away from the fovea. This shift due to eccentric fixation can be assessed and followed up, whether the child is improving or he has the potential for fusion at all. And amblyopes with significant eccentric fixation are challenging to treat. So optical correction has an important role in correcting amblyopia. Esotropia is more amblyogenic. Hypermetropes are more prone to develop amblyopia, and it is ideal to align the eyes during the sensitive period after amblyopia starts improving, and continue patching and amblyopia therapy after surgery. Thank you.
Thank you, Dr. Leila Mohan, for describing the amblyopia caused by strabismus, very difficult topic, with the beautiful videos and